We'll go to the next part of next talk of this session, that is by Dr. Sameer Aggarwal. I think Dr. Sameer Aggarwal is here. Yeah. So this is multifactorial approach to the diabetes management evidence and once weekly GLP-1 RA dulaglutide. So Dr. Professor Sameer, Dr. Sameer Aggarwal is the DM Endocrinology AIMS, Head of Endocrinology and Metabolism at Apex Plus Super Specialty Hospital, Rohtak, Haryana. President Speed Society, for more, you know that, MCA recognized PG teacher, publication in National and International Journal of Repute, recipient of A.V. Gandhi Award for Best Clinical Comment in Endocrinology, main area of interest in metabolic bone disease and osteoporosis in pregnancy and hormone disorder, editor of Insulin Manual and editor manual or pregnancy and thyroid diseases, editor of clinical manual on SGLT2. Welcome, Dr. Sameer. We welcome you here for the rise for the talks.
Thank you, Dr. Madan, for nice words. Thanks all the audience who are still keeping post-lunch session. I think we need definitely multifactorial approach in management of diabetes, and we need to have good innovative drugs in management of type 2 diabetes. Many patients of type 2 diabetes are not being controlled with diet, lifestyle, with combination of oral drugs, and I think each diabetic patient has its own requirement. So you have to tailor the approach according to the patient profile, the affordability and other characteristics of the drugs. GLP analogs like these are called as glucagon-like peptides. These are not being degraded into the blood. So these are good add-on drugs in management of type 2 diabetes. What we have seen in type 2 diabetes is that there is a blunting of GLP effect. So we need an incretin agent. So there are two choices: either you give a DPP4 inhibitor, which are oral drugs, these are good drugs, or you can use a GLP analog. The problem with a native GLP is that it gets degraded in the blood. So if you are using a GLP analog like dulaglutide, then it helps in controlling the blood glucose values, and other advantages with most of the GLP analogs like dulaglutide is that they cause weight loss. So in management of type 2 diabetes, you have few drugs which cause glucose control, and in addition to glucose control they cause weight loss. Metformin, yes, it causes glucose control and little bit of weight loss. SGLT2 inhibitors are, yes, good oral drugs, but then once the GFR drops to below 60, the glycemic reduction efficacy of SGLT2 inhibitors go down. So that's one of the main issues, and also some adverse effects, particularly fungal infections, which most of you have seen in your clinical practice. So here comes the role of GLP analogs. And already we have seen in management of type 2 diabetes is that they are on multiple drugs, and patients are not comfortable being put on another daily drug. So if you are able to reduce the treatment burden with the drug, which can be given like once in a week, I think the acceptability and compliance of the patient improve. So this molecule, which is dulaglutide, it's a GLP analog. That is one of the main advantages, is that patient needs to give this drug just once in a day. And there are some real world studies recently published also which have shown that whenever there was switch over from other incretin drugs to GLP analog like dulaglutide, the HbA1c reduction also improves. And one of the reasons which was given by the patients or which was analyzed was that maybe because the compliance is increased once the patient is put on a GLP analog. But we must know the adverse effects and some issues, like it's a costly molecule, which most other GLP analogs, yes, they have the same treatment cost. But if you are able to have good HbA1c reduction, I think there cannot be anything most cost effective. So ease of use of this dulaglutide or Trulicity pen along with this once a week drug makes it a good innovative drug which has its edge over other GLP analogs. So I think they have insulin and glucagon have different roles in the body. Glucagon definitely leads on to increased hepatic glucose production, and there is a diminished insulin secretion and impaired glucose suppression. You can see in type 2 diabetes you have a diminished insulin secretion and the glucagon levels are high, so that doesn't make a good case for type 2 diabetic patients. And also insulin secretion is enhanced after the oral versus IV administration. So the incretin effect is reduced in people with type 2 diabetes, and this is, you can see after the oral glucose load, this incretin effect increases. So if we talk about GLP analogs, they have effects on various body systems. Predominantly they will cause decreased appetite, they will improve the insulin sensitivity, they cause the weight loss, they decrease the hepatic gluconeogenesis, and the recent data with GLP analogs have also shown that they are cardioprotective. They decrease major adverse cardiovascular outcomes. So these are the GLP analogs which are approved. Broadly, they can be either human GLP or exendin based GLP analogs. Exenatide is a exendin based GLP analogs, and same with lixacenide, which is available in India. But if we talk about human GLP backbone, the weekly therapy, I think we only have dulaglutide or Trulicity at present in India. If we talk about daily, yes, you can have liraglutide daily injections, or you can have oral semaglutide, another oral. It's the only GLP analog which is available orally. But if we talk about weekly, it's only dulaglutide. The problem theoretically which can happen with a exendin based GLP is that theoretically when you give this, it can cause antibody formation, and some studies have shown that it can cause blunting of a GLP action. So that is one of the theoretical issues which can happen with exendin based GLP analogs like lixacenide. But this is not the issue with human GLP based analogs. And if we see the comparison of human GLP and exendin based GLP analog, only 53% homology. So I think this is the octet which you already must have seen in various presentations at what happens in type 2 diabetes. There is increased hepatic glucogenesis, decreased uptake in the skeletal muscle, diminished insulin secretion. Of course, this is one of the predominant thing which happens as type 2 diabetic patients are progressing, and also there is decreased in the incretin effect where we are hitting with these GLP analogs. So there are various drugs which are taking care, but if we see GLP analogs, they act at various levels. They also increase the insulin secretion from beta cell from the pancreas. Simultaneously, they decrease the glucagon secretion also by increasing the cyclic AMP. That's one of the proposed mechanism. And they improve the incretin effect, and they cause weight loss also, which improves insulin sensitivity. And this we have seen clinically, that once you achieve good glycemic control, if you achieve weight loss also, sometimes those patients who are already on insulin, we have to decrease the dose of insulin, or those patients of type 2 diabetes who were not responding to insulin, after introduction of GLP analogs like Trulicity, the glucose levels improved. So I think going beyond A1C to manage complications in type 2 diabetes, it's not only talking about just HbA1c, we have to talk about other things also, particularly cardiovascular disease. And we see that relative risk of CVD during the progression of type 2 diabetes progresses very steeply once the patient is transitioning from normoglycemia to pre-diabetes or to type 2 diabetes. So CVD seems to be the leading cause of morbidity and mortality for individuals with diabetes. So important goals in type 2 diabetic management: to improve the glycemic control, minimize CVD risk factors to reduce the incidence of CV events and mortality, and to use those drugs in management of type 2 diabetes which are cardiovascular safe, which have got good CV safety data. And also post 2008, FDA requires that any new drug which is being launched into the market for type 2 diabetic management must prove that it is cardiovascular safe. So if we talk about benefits of different interventions per 200 diabetic treatment treated for 5 years, I think systolic blood pressure seems to be playing a good role, LDL reduction also, HbA1c reduction also. Moderate weight loss yields substantial long-term cardiovascular disease risk reduction. So I think weight loss greater than equal to 5% associated with improvement not only in HbA1c but also in blood pressure, lipids. So that is, I think, one of the important things, and losing more than equal to 5% body weight during the year after diagnosis associated with lower hazard of CVD events compared with maintaining weight. You can see these values of hazard ratio, so lost more than equal to 5%, significant decrease in the 10-year CVD. So that implies that it's very imperative to hit at the weight part in management of type 2 diabetes. Not only attaining good HbA1c, but simultaneously using a drug which can cause weight loss, and you have very little choices available with you these days. So multifactorial approach to type 2 diabetes, lifestyle modification, glycemic control, lipids, blood pressure control, and smartly selecting the drug is very important. So I think GLP-1 receptor agonist like dulaglutide is offering potential benefits beyond glycemic control, and it also offers anti-atherosclerotic benefits that has been shown by various mechanisms, decreased nitric oxide production and other benefits also which comes with the use of GLP analogs. So taking into account the benefits of GLP analogs and the cardiovascular safety data which has come up with this molecule, ADA and most of the organizations, they feel that once the patient is not responding to combination of diet, metformin and other drugs, and if the patient is having ASCVD indicators of high risk or is suffering from ASCVD, then independently of baseline HbA1c, we should be selecting a drug which is having good effect on cardiovascular disease. And amongst injectable drugs, GLP analogs with proven CVD benefit like dulaglutide should be introduced early on. If you want to use a drug to minimize weight gain or promote weight loss, then again GLP analogs and SGLT2 inhibitors have an edge as compared to other drugs. So in most patients needing injectable therapy to lower HbA1c, GLP-1 receptors are being preferred. In fact, there has been comparisons between insulin also, that why can't we start a basal insulin, but insulin will cause weight gain, so that will not be there with GLP analogs like dulaglutide. So once weekly dulaglutide offers a multifactorial approach in type 2 diabetic management, and these were award studies which compared head-on dulaglutide versus other available drugs in management of diabetes, whether it was versus glargine or whether it was versus liraglutide. So this was very interesting trial where you see HbA1c reduction almost same with dulaglutide and liraglutide. In fact, liraglutide dose which was used as comparison in award 6 was 1.8 milligram of liraglutide, which we rarely use in our clinical practice. Weight loss in fact occurred better with dulaglutide 1.5 milligram as compared to liraglutide in award studies. So if we compare CV outcome trials of available GLP-1 receptor agonist, the REWIND was the one which helped in establishing the confidence with this molecule with regards to MACE outcomes or major adverse cardiovascular events. So if we compare the 3-point MACE, non-fatal MI, non-fatal stroke and CV death, the composite of this 13% benefit, non-significant reduction in other trials of exenatide, good benefit in semaglutide in SUSTAIN 6. In the REWIND, again we have the benefit, but we do not have other CV outcome trials like with exenatide, which is, or with lixacenide, and these are not being used at present. So amongst the GLP-1 receptor agonists, liraglutide and dulaglutide, which are available in India at the moment, has demonstrated protection against major adverse cardiovascular events. And Trulicity in Rewind clearly showed the relative risk of 3-point MACE by 12%. The interesting thing, not majority of the patients were having established CVD at baseline. Median follow-up was around 5.4 years. I think this was very long period, and that was again one of the edge with the Rewind data. And you can see the red line of dulaglutide significantly decreased relative risk of 3-point MACE. So establishing the confidence as a cardiovascular safe drug. So dulaglutide is the first and the only GLP-1 receptor agonist to demonstrate both primary and secondary prevention in type 2 diabetic management. It reduces the risk of major cardiovascular events in adults with type 2 diabetic patients. And if we talk about adverse events, that seems to be common, similar between most of the available GLP molecules. We do not have any serious adverse events. Of course, you have to remember always pancreatitis that can occur with GLP analogs. So we avoid using GLP analogs in patients with previous history suggestive of pancreatitis. Any patient with medullary thyroid carcinoma, we should not use it. Relative contraindication is also there of gastroparesis, which is an autonomic dysfunction. We should avoid using GLP analogs in those patients. So I think benefits of different interventions like systolic blood pressure reduction, LDL reduction, HbA1c control, that seems to be the approach. And reduced microvascular composite outcomes also we have clearly seen, but important thing to talk about is diabetic retinopathy. In fact, that was one of the concerns which was shown by the sustained trial in the semaglutide population. There was increased incidence of retinopathy. So that we still do not know. Maybe the intensive control which happened with this molecule led on to increased retinopathy, but we should be careful which GLP analog is associated with retinopathy, because you are dealing with type 2 diabetic patients and many patients must be having underlying retinopathy. So I think we should not be using those molecules which have adverse events with regards to diabetic retinopathy. I think SUSTAIN showed it. Dulaglutide, it was not significantly there. If we talk about PIONEER with regards to oral semaglutide, numerically it was higher in the oral semaglutide arm as compared to the placebo arm, but significantly it was increased with injectable semaglutide in SUSTAIN 6. So another thing is that dulaglutide can be given at any point of the day. You need not give it in a fasting state, whereas some GLP analogs like oral semaglutide has to be given in the fasting state, and patient doesn't have to eat for next half an hour. So that sometimes is cumbersome for the patient, especially if they are on other drugs which have to be taken in the fasting state like thyroxine. So that can be one of the challenges. Ease of administration, you all know this, that it's very easy, it's almost painless. It can be given at any time of the day. It can be given by the patient himself or herself, and patient, if is injecting at the subcutaneous part at the abdomen, that is the recommended site. The GI side effects, we just ask the patient to they can reduce their concomitant dose of metformin initially. That is one of the things which you can do, but sometimes you give ondansetron as a prophylactic. So initially for a couple of weeks nausea and vomiting can happen, but in most of the patient it goes off with the second or the third doses of Trulicity. So I think we should be going beyond glucocentricity with Trulicity. In addition to HbA1c control, we have a therapy which can cause weight loss and which is having a cardiovascular safety data. If we talk about expectations while initiating GLP agonist, the ease of the use, the efficacy, everything is there. If we talk about oral semaglutide, we still do not have CV benefit data, no dedicated CV outcome trial. The dose titration has to be there. That's another thing, 3 milligrams, 7 and then 14. no need to be given fasting with dulaglutide, so that makes the case stronger. And if we talk about preferences of the patients, then I think once weekly is definitely preferred, as has been shown in the literature also, versus any daily therapy. So patients are definitely preferring a weekly versus the daily oral therapy. Once you demonstrate this pen and how to take it, most of the patients would like to have this. But each patient has its own concerns. So I think dulaglutide is the first GLP agonist to show CV protection in a population where the majority have not been exposed to a CV event. So that is the practical patients you are seeing in your routine clinics, in your OPDs. Good glucose lowering effect with additional benefits and reduction of CV events, and simple device makes this a good thing. Thank you all for your patient hearing.
Thank you, Dr. Sameer sir, for a wonderful lecture. And really, this molecule is a wonderful molecule with this benefit of glycemic and extra glycemic benefits are there. And you have very clearly highlighted that apart from its benefit of glycemic and extra glycemic, it has a wonderful cardiovascular safety benefit. The Rewind trial, which was the largest trial of median follow-up was 5.4 years, has clearly shown that this cardiovascular 3-point MACE reduction was there and the cardiovascular benefits are there. And we have been always looking for the molecule like this. Once weekly, further increase the compliance for uses of this molecule. Thank you, sir, and house is open for question and answer session.
Dr. Sameer, as you are the leading endocrinologist of our place, naturally you must have the maximum number of such patients with you. What are the common side effects you are seeing as a practitioner? Number one, what is the cost of this drug? And these two questions.
So cost of the drug comes somewhere around 8,000 to 9,000 rupees per month, and the side effects which can occur initially in few patients, they occur. So patient selection is very important, sir. One thing, if you have rightly selected a patient, then initially with first injection which can occur is subtle nausea and vomiting and fullness, dyspeptic symptoms, and in most of the patients with second and the third shot it doesn't come. So that is one of the side effect which can occur, and I think it doesn't occur in more than 20% patients. And most of the patients, they tolerate it well.
Question, can it cause hypoglycemia in some patients?
Per se, this drug will not cause hypoglycemia. So if the patient is already on sulfonylurea or insulin, that can cause hypoglycemia. Per se, GLP analogs do not cause hypoglycemia.
I think, sir, we have to stop because of this scarcity of time.
So I will not use it. I will not use semaglutide in those patients who are having active diabetic retinopathy. I will hold on, sir, because there is a adverse signal from the sustained data. And numerically, the number of retinopathy cases in Pioneer 6 also was more. So I will not use, and we do fundus in all patients. So better to hold on.
Is it better, this is what I wanted to ask, is it better to first get the fund examined by a qualified ophthalmologist?
Yes, sir. If already definitely that should always be the routine part, and whenever you are initiating GLP analogs, yes, it's a good thing, especially if you are initiating semaglutide, you must rule out active diabetic retinopathy.
Thank you.
Thank you, sir. Thank you, Sameer sir, for this wonderful session.